So, objectives today really are to consider various frameworks by which to analyze the complexities of international systems. I, I, I don't know if you guys have got a good definition of single payer versus multi-payer versus all payer or the term equity. So I'm going to spend a slide or two on defining those. Have you heard those terms and sort of wondered what the heck they are? All right, well, you'll hear them today and you'll see them in your reading. We'll consider the metrics and concepts by which to compare international systems, and we'll review some of the resources. Hey, how many of you have already sort of gotten at least halfway through your international presentations? Anybody? How many of you have started your international presentations? Okay, well, this is okay, maybe a little bit, Ariana. Thank you. So this is okay, so this will definitely be timely. Good. All right. So first things first, let's look at, and you've heard these terms probably already, but a general classification by health system model. So there's four broad models of health systems. Beverage model, not the type you drink, but in reference to Lord William Beveridge, who was a one of the founding prime ministers under socialized single payer of the UK. So the Beveridge model versus the Bismarck model. We did discuss that, which is a national system administered via intermediaries. Otto von Bismarck, the Chancellor of Germany with the sickness funds in the 1880s. National health insurance, which you might know otherwise in the US as Medicare, via a single payer, which we'll learn about, versus paying for healthcare out of one's pocket without insurance or paying out of pocket for expensive insurance. So these are these four basic models. The Beveridge model is a true socialized single payer system. That is, you have one payer being the government that pays for the cost of all medical care. In the UK, Scandinavia, many other nations, including Cuba and etc., most health facilities are actually built by the government. They're owned by the government, they're managed by the government. Most clinicians and nurses are hired and paid directly by the government. That's what makes it a socialized system. There are, in many of these systems, there are some private doctors who might accept some reimbursement, but for the most part, most clinicians and nurses are hired and paid directly by the government. Such systems are universal, they're compulsory, and they're automatic for residents and citizens. Because of their relative simplicity, and certainly in terms of financing, they have the lowest administrative costs and lowest overall costs, since the government is a monopsony. That is, it controls what gets paid for, what benefits there are, and what fees are provided for doctors, nurses, and staff to provide those services. And it's funded by national taxes. And taxes can be in a variety of fashions, via payroll taxes or via general revenue, or a combination of both. So again, this is true for many Commonwealth countries, United Kingdom, England, New Zealand, Scandinavia, Spain, Cuba. U.S. Veterans Administration actually is an example in the U.S. So we have our own homegrown socialized system. Is this old hat, you guys? Is this like stuff you know well, or is this sort of, okay? So you're here for the right reasons. So, so this beverage model or socialized model is certainly ubiquitous to Scandinavia, Norway, Sweden, and Finland. Then we get to, again, the Bismarck model, which is having multi-payers. That is, there are multiple nonprofit insurance intermediaries. And again, Germany, they arose from the sickness funds of guilds from the Middle Ages. Other countries in Europe, including the Netherlands, France, many, Belgium, many nations have a multi-payer system. And the government tightly regulates the scope of services, has standardizations about policies and interactions between an intermediary and a hospital or a physician. Um, and for these countries, care is being enrolled is compulsory because you pay your taxes to do so, and it's mandated for employers as well as for citizens. And it's funded via a uniform rate of contributions between the employer and the employee. And although there are intermediaries, there's like more than 150, for instance, in Germany, there's centralized control of those local intermediaries. So prices for a procedure is the same across the region, regardless of the insurer, and hence the term all payer I'm going to get to shortly. Hospitals and clinicians, however, unlike a socialized system, are private. They will get salaried by the local hospital, which gets reimbursement for its services through the intermediaries, with a federal kitty of funds getting paid downstream to those intermediaries. And again, these examples would be Switzerland with all of its cantons, I'm sorry, Germany, France, Netherlands, Japan, Belgium, Colombia, and some other South American countries. And I guess the best example in the US would have been Blue Cross Blue Shield in its national distribution. That's the France, I'm sorry, those are the flags of the Netherlands, which are horizontal versus the red, white, and blue of France, which is vertical. So that is the Bismarck model. And there's also a national health insurance model. How does this differ? Well, this is a single payer without intermediaries. So the government serves as the only insurer for those people covered under their health insurance plan. It pays health bills submitted by hospitals and providers as at the set rates and fees of that single intermediary. Now, the US has Medicare as one such example, as we discussed. What was unique to Medicare is the government didn't set the fees and rates. Now it's trying to do so. But when it was first formed, due to acquiescence to the American Medical Association, doctors got to set those fees. So it sort of didn't have all the inherent benefits necessarily of keeping costs down. So these single payer concepts of a national health insurance would be providing reimbursement to private hospitals, clinicians, and nurses again. Those who are eligible for that program, it's universal typically and automatic, and it's funded also by typically payroll taxes or national taxes, and it has very low administrative costs when you have much fewer intermediaries. It's one payer. There may be occasionally other insurers that are allowed depending on the country. And some examples of that is Australia, South Korea, and Canada, Taiwan, which formed from scratch in the 1990s. Did not have a health system prior to that. Costa Rica has a single payer health system and universal health care. And again, original Medicare in the US is based on that model. And here's a picture of Taipei and Taiwan. Um, and lastly, the other basic model would be the out-of-pocket model, which is the case in parts of the US for some folks, and in many undeveloped or non-industrialized nations, which might lack resources, infrastructure, and actual trust in government. It might allow those who are well off to purchase indemnity insurances or private health insurances. Sometimes a community will be able to coordinate funding its residents. There may be microinsurances. There's a variable degree of government public health systems with variable acceptance. And in these countries, often there's a necessity for non-governmental organizations or international support. And some examples would be Sub-Saharan Africa, Nigeria, Sudan, Honduras, Guatemala. Here's a picture of a clinic in Central America, DR, Dominican Republic, etc. Here is a sort of map, and I'm sorry, I will upload. I don't think I uploaded all my slides. You guys recorded it last week, but I'll upload slides as well, and I'll certainly upload today's slides. Here's just a summary chart I created to looking at the various different models. Again, the US uses all four of them, essentially. Um, any questions about this? Just as a reminder, single payer refers typically to a government insurer, such as Medicare, or nations like Australia or Taiwan, etc., that will pay health bills. They actually pay hospitals and providers at set rates as a single intermediary, even though those hospitals are independent. They have very low administrative costs, and they don't typically allow other insurers. A multi-payer system, again, multiple government and private intermediaries. In the US, we allow for multiple negotiations between hospitals and clinics and health systems and those intermediaries. As a consequence, things are less uniform and administrative costs are extraordinary. You will hear a term all payer, and what you have to set your mind around is all payer doesn't refer to the whole general system. All payer refers to how facilities, such as hospitals or doctors, charge a intermediary or government. Basically, all payer refers to a hospital that will be mandated to charge the same price for a specific service to every insurance company, no matter whether it's a private company, Medicaid, Medicare, etc. And as a consequence, it has uniform administrative costs. This is what's used in the multi-payer systems of Germany. The hospitals are all payer. They all have uniform costs for a particular service. And that's used in Germany, France, Japan, and actually the state of Maryland, which we may learn about a little bit later on, which has a carve out to be able to provide all payer um, 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 charges. And it allows basically the public and private insurers to have some pull over the hospital systems. As you might remember from a previous lecture, hospital systems got to run the show because they got so many covered lives. And when they had so many covered lives, they would be favorable in negotiations. If you have one set price and it's controlled, it assures an even playing field between the various intermediary insurers. Yes, Ariana, I'm glad there's a question because some of this is complicated. Yes.
So I just wanted to clarify with the all payer system, are the hospitals and providers setting the price?
No, thank you. Good question. It's typically negotiated between government and the hospital, and there's an intermediary agency. That's what they do. If, for instance, in the state of Maryland, they have an all-payer system. Every hospital charges the same price. If you're on Medicaid and you have an appendectomy, your doctor gets reimbursed and the hospital gets reimbursed the same as if you're on an employee-sponsored insurance. The person who determines that price is usually the governmental agency, essentially, Maryland state agency that looks at this, Germany's national agency that sets these prices between the different payers. That's a really important, and so it takes out the independent negotiation between hospital. I mean, there's an element of that in the US and Maryland, but for the most part, an independent agency determines it. Does that make sense? Good question. Um, okay, so we're getting on to how do you describe a health system, an international or a national health system. So we've talked about models of government coverage, those four models on the chart. And then you get to consider foundational values. That is the mindset of a social of a society. What might be the goals of the system? Do you want to have universal coverage? Is it a traditional expectation? Is it going to be comprehensive versus limited? Will it include traditional Chinese medicines or non-allopathic medical care or chiropractic? Does it consider health services as a public good or a social institution or more of an industry or a commodity as we do in only in the US? So, in thinking about these sort of foundational values, and this is a chart I stole from Akiki Okana, who was a Netherlands professor of international health studies. I liked her framework. So, foundational values might include, for instance, a fraternal responsibility that arises with taking care of members of a guild such as the origins of Bismarck model of care. Maybe a common responsibility for all members of a society, as you might see in Scandinavia with the beverage model. You might have a foundational values of individualism, self-reliance, or libertarian perspectives that some in America hold dear, or market-driven commodity versus social welfare. Again, many nations value veteran services, including in the US. So, ironically, we have a socialized veteran system in the United States. So, all of these are elements of what you might consider foundational values. Again, can I have somebody read this for me, please? I'm getting a hoarse voice. I have a volunteer who hasn't read yet.
I can read it.
Thanks, Natalia.
The Constitutional Chamber has recognized life as the most important good that should be guaranteed by the legal system, giving it the status of principal value within the scale of personal rights. Without its enjoyment, all other rights prove to be useless. Therefore, the court has derived the right to health as fundamental. The above-mentioned law establishes that the health of the population is a public interest good guaranteed by the state.
And anyone hazard a guess which nation this is from? Just call out. We're not moving on till I get some guesses. No points off for being wrong. Therese,
The UK.
UK. How about other guesses? Other thoughts?
United States.
United States. Well, okay. Wouldn't that be nice? Uh, other guesses?
I
Okay,
think
well,
Brazil has a similar statement in their constitution, but I don't think it's Brazil.
well, you're close. You're close. So this is Costa Rica. And when I went, I mentioned to you, when I went to Costa Rica, I was amazed by the level of their healthcare. And that is a developing nation. So these are foundational values that a nation may or may not put into play. They're certainly aspirations. Um, Internationally, there was the Universal Declaration of Human Rights, an International Covenant on Economic, Social, and Cultural Rights, which is actually one of the founding documents of the United Nations from 1948. As of a few years ago, actually, I should update this. As of 6 years ago, the US was one of 86 countries whose constitution did not safeguard citizens' health protection. 130 nations did. Now, it's been at least at some point, the US Supreme Court did upheld that Congress could provide for health care as a right, but it's certainly not part of our Constitution. And we're the only Office of Economic Cooperation and Development, OECD nation, which does not have universal health care in practice or by constitutional right. Now, this is sort of a global picture of the world's constitutions and practice. And not all those countries where it's a guaranteed right, as you see in sub-Saharan Africa or Central America, actually provide care as such. So there is some disparity between what a nation's constitution might value and what gets carried out. But one thing you will never see is that once a nation has created universal health care, it will never be repealed. And here are all these different countries about when they first did develop and not just constitutionally, but in fact, create their universal health systems, none of which have been repealed. Norway was actually 1912. Isn't that interesting? Um, so, what are some of the foundational values in our non-system? We talked about this in previous discussions. Also, the U.S. in previous, much less so now, the number of folks who are affiliated with a church or religious organization is quite low compared to our history. But in its founding, centrality of religion and interpersonal rather than institutional charity were sort of the origins of the pilgrims and what followed in the colonial days. Again, in the US, we have an element of federalism, which is not unique to the United States. So Germany has various provinces, Switzerland has cantons. Every country has independent degrees for each independent state. But what was unique to the US was highly defended state rights arising from slavery, which does, I think, probably have some carryover in terms of our institutionalized perspectives on limited care for those who are, quote, undeserving or felt um, um, such. Anyhow, we discussed a little bit as a Great Depression created a unique period where government and social safety nets were rapidly created, and Medicare in 65 coming out of the New Deal. And what we've seen in the past 40 years is a concerted deconstruction of that administrative state due to concepts of neoliberalism, privatization, and deregulation. Can you guys all get an impact and understanding what an individual country you're studying has in this fashion? Only if you're extraordinarily ambitious or you're from that country can you learn some of the, might you know some of these things. But whatever reflections you can take from a country's history would be super. I'm just gonna, in terms of how change happens politically, again, something that's unique to the United States is the role of the legal system, which has sort of served as the major remedy when legislation is not successful. And that goes back actually to de Tocqueville in the United States in the 1800s. Um, so, um, so that's what we're talking about in terms of foundational values. And then we get, I think, to the key of what you're going to be doing in your presentations, which are the structural elements. I might have woken you up just now. So what are the specific elements of a country's health system that is worth learning from? Well, so there's about the WHO has World Health Organization had 6 elements. Kiki Akma had maybe three. I've got sort of amalgam here of various structural elements. So number one, service delivery. That is, how is care accessible via a primary care doctor? Is care accessible via a specialist? Are there shortages of certain specialists? Is there home care? Is there long-term care? Can people receive long-term care in their homes? Well, how is coverage to an emergency room provided? Are medications covered? So that's the elements of service delivery. In a particular health system, who is it and how are they paid if you're in the healthcare workforce? So are there community health workers? Are there public health workers? How are they licensed? That's relatively less important, but the number of providers are going to be quite different between Cuba, which is a socialized system, versus Scandinavia. What's the infrastructure of the facilities? Are the hospitals modern? Or are they using portable X-ray devices from the 1910s? What's the level of technology? How do they provide electronic medical records if provided? These are all information that you're are readily accessible and are interesting to present. So what does that infrastructure look like? Um, Financing, which is key. How are government services funded by payroll taxes, general revenue? Is it a for-profit, investor-owned hospital systems, etc.? And then we get to some more of the granular nitty-gritty. What are the contractual designs between the funding of a hospital or a clinic? Is it fee for service, as it is in many countries, or is it managed care and capitated? And many countries have both now. Again, do hospitals receive a lump sum for their yearly services as a global budget? Or do they have incentives to provide more days in the hospital and more services via fee for service? So, what's the contractual design? And lastly, um, who has power over the flow of money and expenditures? What is the governance? If you have a multi-payer system, what degree of control does the independent sickness fund have versus the federal government? Who determines those services or benefits? How does a nation determine whether long-term care gets covered, whether medication gets covered, what preventative services get covered? And how is it priced? So, and again, in terms of what particular services or technologies are covered, in the United States, we have the U.S. Preventative Services Task Force, which fortunately the Supreme Court let off the hook and was not decimated, and so will remain a player in determining whether colonoscopies are valuable versus mammographies, etc. And in England and UK, you have the National Institute for um, something in the NICE system. Uh, and we'll get to that in a future slide. So we've talked about foundational values, and how about the more specifics in terms of financing? Again, is it a welfare program, a social insurance that's funded by government taxation? Are the hospitals private or government owned? Are they charitable or investor owned? How does the money flow? How is it contractually done, fee for service versus capitated? Are there global budgets? And who owns the hospitals? Are they built by the government? Are they privately owned by a community or owned like Healthcare of America or Tenant being investor owned? So, and then we have governance and power over expenditures and regulation of healthcare, which also includes, by the way, things like labor regulations and licensing and the like. So this is just another, this is the same thing in 5 different elements: financing, access, governance, provider payment, health for workforce, and technology. Um, and I do want to spend a minute. So it's the National Institute for Health and Care Excellence. I can never remember what NICE stands for. And this is UK's National Health Service program. It's an independent panel that evaluates whether a new drug should be covered or a new type of pacemaker should be covered. Is that drug or treatment or test safe, effective? Does it add value? Is it worth it? Hence, a new chemotherapeutic agent might be very costly, perhaps provide 1 month of additional life expectancy, but have major side effects such that it would not add much to clinical benefit. Um, by the way, and every major international health system has such forms of evaluative governance. They help also with the process of negotiating prices with the manufacturer. So, for instance, and we'll hear from Thomas Lane about Swedish national guidelines. Germany has its own institutes, etc. Um, by the way, unlike many other nations, our Food and Drug Administration does approve new medications or biologics as compared to placebo. And we're going to learn about this when you guys learn about pharmaceuticals. So if it's better than placebo, the FDA will approve it. It does not do comparative evaluation or assess value of a particular medication. And that's an important element to be aware of in the US. So we've talked about the three other prior elements. It's major system paradigm, foundational values, structural elements, and then we get to outcomes. And this is more a comparative analysis between nations. And there's a variety of programs, OECD, Commonwealth Fund, that look at particular metrics of health outcomes, such as life expectancy, infant mortality, avoidable mortality, or that is mortality amenable to care, that is preventing the death from stroke from uncontrolled hypertension, or the amputation and death related to uncontrolled diabetes. So that's an important measure. So we have overall population outcomes. Then you could also look specifically about outcomes for select populations, poor, children, families, elderly, veterans, etc., minorities and ethnic groups. Um, so that's outcomes and metrics. You could look at how a system performs overall. That is, how is its access? And by the way, which usually correlates with outcome. How is the ability to access care? What's the efficiency that would have major impacts on health expenditures? Is the process a high quality process? And is there equity between various groups within a society? Um, what is the health expenditure, either per capita or in a percentage of gross domestic product? And again, how efficient is the overhead for performing that program, the administrative efficiency? So I think you'll find as you look at most other industrialized nations that those nations consider healthcare a responsibility of government. Therese, yes.
I was just wondering if they look at patient satisfaction and also
Yes.
if malpractice insurance is as big a thing in other countries as it is in the US.
Yeah, so really good question. I'm going to show some slides about the granular details in determining these metrics. I mean, this is not a new thing. This has been done by OECD and various researchers, World Bank, as well as independent funds like the Commonwealth Fund, etc. They ask billions of questions, including patient satisfaction. Those slides I might have shown you with primary care about when was, do you identify with someone you've known for more than 5 years? How, do you have a place that you recognize your care as being? There's a whole series of questions, yes, that are specifically asked of populations of people in surveys. So that's an important question, and that's how these numbers are determined. The specifically in terms of system performance, in terms of health outcomes, they're often gathered independently by nations as well as OECD and CDC, for instance, in terms of life expectancy, infant mortality, etc. Does that make sense? Um, so again, um, we'll just again, you know that we're outliers in all of these elements. And here we're starting to look at, again, some of these specific, for instance, healthcare system performance. How do we rank? We don't rank well, but these are five determinants: access to care, care process, equity, for instance, is another one. Um, so the more specifically regarding these indicators, something called care process means how well does a medical system and its clinicians coordinate care between subspecialists and primary care? How safe is that care? If you're getting an indwelling catheter or central line, what's the incidence of central line infections or sepsis or postoperative joint infections? How are you doing with your distribution of colonoscopies or preventative care, immunizations? And importantly, how do you engage your patient in determining that particular person's goals of care? Again, the US prizes autonomy, and we do actually fairly well, by the way, in terms of care process. So if you look at the US, we do actually the best in care process compared to our dismal rating in all the other metrics. So you guys learn a lot about really respecting your patient's goals of care, and Kleinman questions, understanding what your patient understands about their disease, safety, and etc. Not so well on other measures. Access, of course, affordability, major issue because insurance is instrumental in determining that. We talked about a dearth of primary care clinicians and disparities across rural versus urban areas. Again, administrative efficiency. You may have heard a little bit from Wendell Potter. I'm not sure he talked about that today, but huge differences. Equity, and then these other metrics of outcome. Again, the US does pretty well in cancer care. Actually, compared to the rest of the world, cancer care in the US is pretty good, although everything else is not so great. And unfortunately, because of absence of insurance, I mean, we have the tools and the training. You guys are learning and will be learning how to help patients manage their chronic diseases, how you manage chronic diseases, the whole slew of new medicines we have for diabetes and the like. But without the insurance to get their care, obviously, we don't do so well. You've heard the word equity, by the way. And I'm just going to throw this out, a few terms that are worth knowing as well. So, health disparity refers to significant differences in health outcomes between different populations of peoples, and that's extreme in the US. Health inequity means the unjust distribution of resources between populations, which results in disparity. And health inequities are deemed to be unfair, unjust, avoidable, or unnecessary when they can be reduced or remedied through policy action. Other countries have made major efforts to limit health inequities to varying degrees. Canada has its issues, we have our issues. So overall, what is health equity? When everyone has what they need to attain their highest level of health, or the absence of avoidable differences among socioeconomic and demographic groups, or geographic areas in health status and health outcomes. So just to touch on that a little bit. This is so a couple of resources in terms of comparative analysis. A Commonwealth Fund, as I mentioned, easily accessible. How many of you have gone online to look at the Commonwealth Fund, or any of you to date? So they have a lot of specific information about countries. Not only does it give you like overall value in terms of who's doing well, who's not, but you could click on a flag when you get to the Commonwealth Fund to look up a particular nation that you might be interested in studying. So that's one such resource. This is a terrific program, which is this Euro Health Observatory. And they have really detailed analyses, maybe more detailed than you may wish, about all these different elements: financing, healthcare delivery, public health outcomes, COVID-19. And for instance, this is just from last year from Denmark. You click on this and download. They're really quite comprehensive analyses of various nations. And again, I'll upload the slides, and you guys, I think, I don't think this isn't Betty's information, so I think this would be an adjunct to that. So it's 1:43. I have a couple minutes early, but I guess something I'm just going to throw out to consider is in the world we're living in, knowing what you know about America's history and status, how would you move forward to build on existing systems for healthcare reform? Is that even feasible in the world we live in? I think that you will see that it is in your lifetimes, because I think that we're not going to have much option but to create great reform. And secondly, in your learning about other nations' health systems, how might that help inform how we move forward? So anyhow, oh, one more thing. When you guys create your presentations, health maps have their utility, but they are, so this is the UK's National Health Service. This is not so helpful. You really have to go through this pretty detailed to figure out what we're looking at and what its relevance is. I think a more simplified health map to make because you could create it in 1,000 different ways to demonstrate the issues that you're trying to bring home. This is also for the structure of the national health system in England. Again, it's a little bit, it has defined by national bodies, regional bodies, local bodies, service providers. It's a little bit more coherent. So just another thing to consider when you're creating your presentations. Here's actually, this is not too bad given how complex the US system is. By the way, you'll learn that some systems are much more complex than other systems, and that usually adds to cost and inefficiencies. But again, our system is complicated in a way that it creates high profit, high medical debt, and as we're going to be seeing in the near future, many uninsured. It's going to probably go up from 8.5% uninsured back to the 20s or 30% we've seen, unless something's done after this recent legislation gets passed. Anyhow, who knows? Maybe it won't get passed.